This is an introduction to economic evaluation for public health practitioners. It's part of the online training resource on public health evaluation. It's designed to be used in conjunction with the training notes and the learning questions. And we've also given you some suggestions for further reading if you want to know more about any aspects of economic evaluation in public health. Public health professions frequently make decisions on which programmes and projects to allocate resources and funding to. And as well as that, they're also involved in evaluating programme and projects which address public health concerns, or even just in commissioning these evaluations and reading reports on them. So increasingly, evaluations in the public sector are expected to have an economic component. This part of the resource will support you to carry this out, commission these evaluations, and just generally have a better understanding of reports and papers written on this subject. It will do this by describing some of the key terms in economic evaluation and by using examples to describe when each of them are used. And this will help you to make decisions about alternative courses of action. In particular, what works best, how this can be achieved most efficiently, and who will benefit. Economics has been called the science of choosing. Economics is about allocating scarce resources, so it's not just about calculating the cost of something, although it's often confused with this, but about looking at the effectiveness of how money is spent. The resources will always be scarce because we'll always need, want, or wish for more than resources available. Public funds need to be spent in the way that creates the greatest benefit for the greatest amount of people, or targets a particular group effectively. The application of health economics reflects a universal desire to obtain maximum value for money by ensuring not just the clinical effectiveness, but also the cost effectiveness of healthcare provision. As you know, public health resources also have to be publicly accountable, and using economic evaluation helps to make public spend more transparent. As I mentioned, that economics is different from accounting, as it also considers the alternative use of resources. That's called the opportunity costs, which I'll go into in more detail next slide. But in brief, that means not just the costs, but the alternative use of the resources. So opportunity costs in more detail is one of the key differences between economics and accounts, and it's considered to be one of the key parts of economics. It considers not just the costs of doing something, but also the other opportunities that have to be given up as a result. What this means is that as well as considering what resources will be used for public health intervention, you must also consider the fact that these resources are now no longer available to fund alternative beneficial services. So for example, if a programme is funded for a yoga scheme for elderly people with the aim of improving strength and flexibility and decreasing falls, then that means you no longer have the money to fund, for example, a mental health intervention for teenagers. This means that the loss of the mental health scheme for teenagers is one of the opportunity costs of the yoga scheme. Just in your personal life, if you wanted to buy an expensive car and this meant that you couldn't go out for a year, then the opportunity cost of the car would be your social life. Health economics can be used for a variety of things: choosing priorities in healthcare, justifying the use of resources by showing how they were spent and what was achieved, attributing monetary value to all impacts of any proposed policy, project or programme, which can be really challenging. For example, think about how difficult it might be to calculate the monetary value of a vaccination programme or public health information on something like alcohol on television. But it's really helpful and important to attribute monetary value, as it gives us a common measure to compare quite different interventions. Economics is also useful for assessing resource requirements in the future. For example, how much money will we need for older people's social care in the future if older people live longer but in frail health? What about if they live longer in good health? What about if they take out their own healthcare insurance? Economics allows us to look at the effects of these different scenarios on government resources. It also allows us to understand the cost spent for the benefits achieved, and it supports the development of health policy by assessing different approaches to a health problem, what this will cost and who will benefit. helps us assess whether spend is in alignment with government policy. For example, the UK government are very keen to reduce inequalities. So if you were considering funding a project, you might want to consider its effects on health inequalities, focus on for example, on neighbourhood deprivation, or the effects on different ethnic groups, or whether the programme in question would be of benefit to disabled people, depending on the area of inequalities that you're interested in. Economic evaluation also helps identify other possible approaches which may achieve similar results, and it improves evidence-based decision making. For example, exploring whether an approach has been shown to be economically effective in the related literature where that's available. There are many examples of economic evaluation in public health. As we begin to see, health economics can be used to compare the effectiveness of health programmes with completely different goals, such as measuring the economic effectiveness of smoking in public places ban for reducing smoking related diseases, and comparing this to a public health campaign on binge drinking for reducing alcohol consumption. So we're looking at two different things here, but by giving a monetary value to it, we're able to compare the most benefit for each of those. And this is an analysis of cost benefit. It can also be used to compare the most cost effective way of achieving the same goal. And that's an example of cost effectiveness analysis, which I'll describe later. If you wanted to decrease childhood obesity, would it be more effective to introduce more exercise into primary schools, tax children's sweets, or educate parents about diet? Or, for example, is providing improved palliative care support at home a better use of resources than building a new hospice? The next set of slides describes common terms used in health economics and when they are used. The accompanying learning notes also include a glossary, which is more expansive, and that has other common health economic terms. Cost-benefit analysis is analysis that compares the cost of alternative ways of producing the same or similar outputs in order to assess how to achieve results in the way that's most effective and the most efficient. For example, if the government aimed to decrease cervical cancer, what would be most cost-effective? Would it be vaccinations for young women, sex education generally, or regular cervical smear tests? Cost-effectiveness analysis allows us to determine this. Cost-benefit analyses goes further than cost-effectiveness analyses by placing a monetary value on the changes in outcomes as well. This means that cost-benefit analysis can examine whether the benefits of a policy outweigh the costs, as well as compare policies which are associated with quite different types of outcome. I mentioned some examples of that earlier. So rather than comparing 3 different approaches to reducing cervical cancer, with all approaches leading to the same goal, it can compare different programmes. For example, whether more benefits will accrue from an exercise scheme in schools or a diabetes prevention campaign for middle-aged men. Cost-benefit analysis quantifies many of the costs and benefits of a policy as possible, including the wider social and environmental impacts, such as crime, air pollution, traffic accidents and so on, where this is feasible. Cost utility analysis is a bit more complex. It's used to determine the costs in terms of utilities, especially the quantity and quality of life, and it's closely related to QALYs. I'll discuss QALYs more in the next slide. It's useful because it allows comparison between quite different outcomes, but it's challenging to do because it's difficult to put a value on health status, and that depends on individual perceptions, and also about stages in life as well. We tend to hear quite a lot about QALYs these days, which is quality adjusted life years, and we tend to hear a lot coming out of NICE when they are deciding whether to accept a drug or treatment on the NHS. So what are they talking about? A quality adjusted life year, a QALY, takes into account both the quantity and quality of life of a health state, or that generated by healthcare intervention. It's a arithmetic product of life expectancy and a measure of the quality of the remaining life years. A QALY calculation places a weight on time in different health status, so a year of perfect health is worth 1, and a year of less than perfect health is worth less than 1. Death is considered to be equal to 0, and some health statuses might be considered to be worse than death, perhaps being in a coma, for example, and have negative scores. So, for example, a person might consider that they would swap 8 years of life with back pain with 5 years of life with perfect health. In this case, a year of life with back pain is worth 5/8 of a year in perfect health, in that person's opinion. In this way, comparisons can be made between interventions, and priorities can be informed by understanding which interventions have a low cost per QALY and which have a high cost per QALY. Of course, they're really not perfect. People will judge different health states differently. To some degree, it will depend on how much money they have and how they feel their life would be limited by different conditions. However, different patient groups are always competing for the same scarce resources, and QALYs are very useful in resource allocation decisions and means that the decision-making process is explicit. Also, commissioners are helped to understand the likely benefits from investing in different technologies and services and therapies. One of the important things to consider is perspectives in economics. Costs and benefits aren't fixed, they change depending on whose perspective is being considered. Traditionally, the NHS was a bit guilty of only considering its own perspective, and often even that only of its own department. However, different areas of healthcare impact on each other, and there are also strong relationships between health and social care. In addition, health is related to wider social contexts, including education, employment, and environmental factors. Thinking, for example, if health commissioners decided to be most economically effective to locate sexual health services in one central area and close down the smaller local services in the neighbourhood. Let's think about that from different perspectives. From the public health commissioning perspective, locating the service centrally means that they can make more efficient use of staff, more efficient use of the building, and we can reduce administrative costs. They can see patients in less time, and overall they can reduce costs and increase benefits. From the patient's perspective, that might not be the case. They might have to travel further and take time off work, and this might decrease their use of the service. As a result, it might increase the number of sexually transmitted infections or unwanted pregnancies. Alternatively, they might prefer the anonymity of a service which is not in their community. So in this scenario, the cost-benefit analysis is likely to show the costs going up and the benefits going down, making it economically ineffective for patients. Then there's GPs. Their perspective might be that they now have to deal with a lot more patients who use them as an alternative for this kind of advice, and this would lead to increased waiting times, more costs, and for the GP having less time for what they consider to be more urgent appointments. From societies in the wider healthcare perspective, it might lead to more unwanted pregnancies, more terminations, and more health problems with costs associated with that. So as you can see, when you look at the different perspectives, you get a different sense of where the costs and benefits are. And it's important to remember that costs and benefits change depending on whose perspective is being considered. So an economic evaluation should make explicit whose perspective is being considered and try to involve as many stakeholders as possible. Another example of that would be hospitals might save costs by releasing patients earlier, but this means that costs are spent in the community, for example by district nurses visiting patients at home or increased GP attendance. At a wider level, it may mean family members taking time off work, leading to reduced earnings. So again, a full economic analysis should consider the costs and benefits to all of these stakeholders when it's possible. One other challenge of perspective and of economics generally is that often money might be spent from one budget, but the benefits are felt elsewhere. So for example, a hospital policy to reduce bed days in the elderly might have a large impact on social care who support people in the community. The hospitals save money, but social care has not necessarily been given any more money to make up that loss. And these situations can be challenging as it's difficult to show direct causality between spend and save, and also very difficult to persuade another agency to move the budget to you. This is also challenging in public health prevention, where not only is it difficult to show causality, for example between a smoking cessation campaign and later lung cancer, but it can take many years before one thing has an effect on the other. Full economic costing does attempt to address this, but it'll always be challenging. Health and social care in particular have strong links, and changes in one are often felt in the other. And there's been various attempts to try things out. There was a pilot project for older people which tried to show how early intervention caused savings in acute treatment, and the intentions of moving money from acute treatment to early intervention if it could be proven. And that's going to be very challenging to do, but it's really worth a try. So again, it's got to think about the perspective of who's involved. Another term I want to mention briefly is discounting. In brief, people tend to prefer to receive goods and services now and to pay for them later. In public health terms, that's why it can be hard to get people to stop smoking or drinking alcohol, because they think more of immediate enjoyment than future health concerns. Discounting is a formula that adjusts for this by calculating a percentage reduction on later benefits rather than immediate benefits when carrying out a cost benefits analysis. However, there is a great deal of disagreement in the field of discounting, both in terms of how much future benefits should be discounted and whether discounting should be carried out at all. For example, economists have argued that while an individual might wish to smoke now and ignore the effects of future health, we should consider things from a society's perspective, and society in general would prefer people not to smoke, and for there not to be the cost of smoking related illnesses in the future. It's too much detail to go into now, but you can read more about it in the references associated with this presentation, and you can follow that up if you wish. In economics, we want to get the greatest benefits for the most people using the least resources, and that's what's known as efficiency. Efficiency evaluates how well we are doing this. You might have come across the term Pareto's efficiency. This means that resources have been allocated in a way where it's impossible to make any one individual better off without making at least one individual worse off. In public health, it can be challenging, if not impossible, to do full economic analysis, and we've seen examples of that up to now. Often the information is not available, or it's not possible to collect it. Staff do not have economic skills, or there's not enough time to carry out this process. In addition, the level of economic evidence, especially in public health, is not high. Further, it's hard to restructure services, and so services might be provided in the way that they were in the past, rather than because they are the best from a health economic perspective. Nonetheless, there is increasing expectations that some cost of benefit analyses will be part of grant applications and evaluations, and this means that greater economic evidence will be available in the future. Of course, economic decision making doesn't take place in a vacuum. We can't make an academic decision between different courses of action and then immediately implement the most cost effective one. Services are already in place, staff are already employed, the public are already using services in a particular way. This means that changes can often only take place incrementally, if at all. A common example of this is when there's a decision made to close down or relocate a hospital for economic reasons, and this can prove almost impossible to do, as local people will campaign strongly against this. So that means that as well as looking at the cost and how many people benefit, you also have to think about the context of where the resources are being allocated. So you think about what's already going on in this area, what has happened in the past, and what skills are available, as well as who will benefit from the resources. There's also skill shortages in some areas, and it's also quite difficult to lose staff and employ new ones, even if this is theoretically more cost effective. So if you were to allow nurses a greater role in prescribing, you might have to work out whether there was enough nurses who had that skill before you made any recommendations. Also, resources are not always allocated solely on the basis of pure cost and benefit. As we've seen, they also be made on the basis of government and local priorities and on healthcare policy. For example, there are health policies to reduce health inequalities and to decrease childhood obesity. So as well as allocating money to programmes which help the most people in the best way, programme managers are also going to allocate money to programmes which help particular groups of people, such as those who live in deprived areas. There's also a requirement in the UK that decisions take account of equality issues such as gender, disability, ethnicity, and so on. This means even if a course of action was the most economically effective and gave the most benefit for the most people, consideration has to be made about whether a group are discriminated from receiving this. So for example, if you were making a decision between funding a walking group for the over 60s or implementing a football programme for 7-year-olds, health funders would consider the costs and benefits of each programme, but then they might also consider if either of these groups were a government priority. So they might be more likely to fund the older people's walking group if this was taking place in a deprived area, and to fund the football group if it was demonstrated that being a member of a football group led to weight loss in children. They might also consider the demographic profile of the area, for example, if there is proportionally higher number of children or of older people, and what services are already in place for these groups, and what staff skills are available. A talk like this can only touch on the main themes in health economic evaluation. Alongside this area are the learning notes, and these contain some questions for you to test your understanding as you go along. And we've also added a list of resources that this training has been based on. I won't go into them in particular detail, but they're included in the associated learning notes as well, alongside a short outline, and that describes when they're the most useful. There are also some other useful resources in health economic evaluation which I thought you might want to have a look at, and there's some links to these resources in the learning notes and a short description of each of them. Thank you very much. I do hope this talk will support you in using health economics in evaluation work, and please do look at the accompanying learning notes and the other resources that are available.